Hello, I'm Jan Leifman.
I'm Gayatri from Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Aasma Shaukat. Dr. Shaukat is the Robert M. and Mary H. Glickman Professor of Gastroenterology and Medicine and the Director of GI Outcomes Research and co-director of the K2R programs for the CTSI at the NYU Grossman School of Medicine.
In today's presentation, Dr. Shaukat discusses the most recent advancements in colorectal cancer screening.
Did you know that Dr. Shaukat is a global leader in translational research on colorectal cancer screening and its indications for long-term outcomes and prevention? She also has multiple federal merit awards to study quality indicators for colonoscopy, such as adenoma detection, and also a PI on clinical trials to study the role of artificial intelligence in colonoscopy and blood-based colon cancer screening tests. She's also a recipient of many prestigious national and international awards, including the American College of Gastroenterology's Governor's Award for Excellence in Clinical Research, and also the Senior Governor's Award for Excellence from the American College of Gastroenterology.
She is most certainly an inspirational global leader in the field of medicine.
So let's tune in. Let's tune in and learn from this great keynote speaker and global pioneer.
I'm going to take you back to 2016, and that's where the story begins. So what did we know in 2016, which, mind you, wasn't very far back? We were screening individuals between ages 50 to 75 for colorectal cancer. These were the U.S. Preventive Services Task Force guidelines. And in terms of the modality for screening, there was no one preferred screening test, but the guideline recommended 7 different tests in 8 different strategies. And because of lack of comparative effectiveness studies, pretty much said one or more of these should be offered. These included GOAC-FOBT, fecal immunochemical testing or FIT, the FIT DNA test, flexible sigmoidoscopy, a combination of flexible sigmoidoscopy and FIT, colonoscopy, CT colonography, or the Septin9 DNA blood test. So this created a lot of confusion amongst provider, healthcare systems, and patients about how they should go about screening, but we were pretty much consistent on screening at ages 50 and older. So then in 2018, the American Cancer Society updated its colon cancer screening guidelines, and for the first time gave a qualified recommendation to lower the screening age to begin at 45. The reason for this was this rising incidence in colon and rectal cancers in individuals younger than 50. And the guideline was informed by modeling studies using 2 of the 3 CISNET models, the MISCAN and SIMCRC, which model the effect of screening starting at age 45 versus 50, using different modalities, and look at life years gained to understand which strategy might be better. And these are some of the data that were quoted in the guideline and were emerging. So on the bottom of this graph, you see colon cancer incidence in men and women in the US over time. And you can see there's a nice downward trend for both men and women in terms of incidence of colorectal cancer, particularly over the last 15 years or so, thought largely due to the effect of colon cancer screening. However, if you look at the top part of this graph, it's colon cancer incidence in younger individuals between the ages of 20 to 49. And there, for both men and women, you see those curves have been relatively flat over time. And in the last 10 years or so, there seems to be an uptick or an upward trend in rising incidence. And it's truly this increasing incidence which was the basis for a lot of this alarm and newer recommendations. Now, looking at colon cancer incidence in the US by 5-year increments of age, the one thing you notice in this graph is incidence of colorectal cancer is very much age dependent. Age is the biggest risk factor for colorectal cancer. And looking at this graph, where would you draw the line to initiate colon cancer screening? Largely, studies have demonstrated that when a population's rate is anywhere 30 per 100,000 or higher, screening is both effective and cost effective. And you see that inflection point now at ages 45 to 49. So that's perhaps one of the strongest epidemiologic trends and arguments for initiating screening at age 45. The other interesting finding is that there's a really large bump of incidence of colorectal cancer right at age 50. And clearly, there's nothing magical about 50, except these are probably cancers that were starting to develop, say, between 45 and 49, and were suddenly diagnosed at 50. So that begs the question that if we were to start screening at an earlier age, could we detect these cancers a little bit earlier, perhaps at the precancerous stage, and kind of curb this big rise or incidence right at age 50? Along with that, there's other supporting data. So on the left side of this graph, what you see is the annual percentage change over time for colorectal cancer incidence by decade of age. And you can see that for ages 50 and older, there has been a negative annual percentage change, meaning the incidence has declined over time. However, for ages younger than 50, there's actually a positive annual percentage change, which implies that the incidence of cancer has gone up over time for this age group. And a lot of that increase is in non-Hispanic whites, also American Indians, Alaskan Natives, more than other race and ethnicities. The right side of this graph demonstrates what's known as the birth cohort effect. So this compares everybody born after 1960 to people born in 1940s and onwards. And you can see individuals born, particularly say in the 1970s and later, carry a lifetime increased risk of colorectal cancer compared to cohorts born in 1940. So this isn't a certain time period or years that are affected, but it's truly that entire cohort carries a lifetime increased burden. So these were some of the compelling data that helped inform the guidelines. One might ask a question that perhaps we're detecting more colon cancer at younger ages in the US because we're just doing more colonoscopy. It's more readily available. So maybe for other indications, abdominal pain, diarrhea, we're just having a lower threshold and performing more colonoscopy and picking up cancers that we would have also otherwise had we waited until age 50. Well, this study seems to suggest otherwise. So this is, again, incidence of colorectal cancer by disease stage at diagnosis over calendar years. And you can see there's been an upward trend or increase in colon cancer incidence. And that increase is in all stages of disease, not just local, where one could argue that these would be cancers which would be indolent and still present at age 50, but also an increase in regional and distant spread cancers, suggesting that really we need to be screening them even earlier than we are right now to catch them at earlier stages. So in spring of 2021, we led the ACG clinical guidelines on colorectal cancer. And based on this and other evidence that's summarized in this guideline, we recommended lowering the screening age to 45 to mitigate this rising incidence of advanced adenomas, colon cancer, and eventually mortality from colorectal cancer. And then the US Preventive Services Task Force also updated its recommendation in the fall of 2021 and recommends screening average risk men and women starting at age 45 and gave it a grade B recommendation, which means there's moderate certainty that there's at least a moderate net benefit. The recommended strategies are still several, and they include high sensitivity coag FOBT, or a fecal immunochemical test done every year, a stool DNA FIT test every 1 to 3 years, CT colonography every 5 years, a flexible sigmoidoscopy every 5 years, a combination of the two, or colonoscopy. In general, things that the US Preventive Services Task Force gives a grade A or B recommendations are generally covered by Medicare, and most of the payers tend to follow Medicare. So very rapidly, this is covered by all major payers in the US. Now, the benefits of earlier age at screening need to be weighed very carefully against the harms. The benefits might be that we could reduce incidence in this younger age group with this rising incidence, and also in the process, boost screening in the 50 to 55-year-old, where screening rates tend to be lower. That needs to be balanced against the harms of screening, particularly when we think of colonoscopy being an invasive test. Do we have enough access? Do we have enough capacity? Do we have enough resources to screen individuals and bring them in? And we don't want to worsen disparities, meaning the people at the front of the line shouldn't be the ones that have good healthcare, good access, and crowd out the capacity for people that truly could benefit from screening. So those are some of the things to weigh and balance against each other. Now, let's look at the benefits versus harms from the modeling studies. So again, going back to the US Preventive Services Task Force document, they did perform modeling study. And the modeling studies suggest that the benefit of screening at age 45 compared to 50 is that we would avert an additional 3 cases of colorectal cancer per 1,000 individuals screened. And you can see, regardless of which screening modality is used, that number is between 2 and 3. Now, what are the harms of screening? In screening at age 45 compared to age 50 will also cause harms in about 0.2 to 2 per 1,000 individuals screened. So again, while we're producing benefits, we're also accruing harms. And these two need to be weighed closely. Particularly if a colonoscopy only strategy is used, the harms are not trivial. 2 per 1,000 individuals screened could potentially be harmed. So how do we balance the two? The other thing to think about in this context is, what about the burden of screening on our healthcare system? So by starting screening at age 45 compared to age 50, in the red box, you see how many additional colonoscopies we would need to perform for 1,000 individuals screened. And that number is not trivial, particularly with a colonoscopy-only strategy. And there's other tests that would result as downstream sequelae of that screening cascade. So that number is pretty large. And the question is, do we have healthcare systems that can absorb this kind of an increased demand? And that, again, is yet to be determined. If we look at the US overall, the screening rates are not consistent, and it varies very widely by geography. And you can see states in the Northeast or the Northwest tend to do better than states in the South and Southwest. Overall, screening rates are 64% if you were to average this entire checkerboard. And screening rates vary by race. Whites have the highest screening rates, followed by African Americans and Asians a bit lower. And as we mentioned, screening rates vary by geography. In New York, screening rates are as high as 72% in communities, whereas down in Texas, particularly South Texas, screening rates are much, much lower, 17 to 37%. So we need to first be improving screening rates in 50 and older and kind of make all the screening rates more uniform. But then by changing these guidelines, we've unleashed a storm of another 21 million adults in the US that are between the ages of 45 to 49 that are suddenly screen eligible. So how do we balance screening this increased load and doing it in a very equitable and organized fashion? And those are some of our challenges. Next, I'm going to pivot to family history. This is something that comes up very often with patients and providers. And here's what the guidelines recommend. So with family history, it's important to ask, was it a first-degree relative or not? And first-degree relatives are only parents, siblings, or children, and that's it. And then the next thing to ask is, was the cancer or advanced adenoma in that first-degree relative occur when they were younger or older than age 60. If there's a family history of one first-degree relative who was younger than 60 at the time of diagnosis, or more than two first-degree relatives any age with either cancer or advanced adenoma, the only recommended modality for screening is colonoscopy, starting at age 40 and done every 5 years. What we get more often is one first-degree relative that was older than 60 at the time of their diagnosis. And in those scenarios, the recommendations are to start screening at age 40, but use any modality, and then follow average risk intervals. So for instance, if a colonoscopy is done at age 40 and that's normal, the next one in interval would be 10 years. One second-degree relative at any age, which is another common history we get, somebody having a grandparent with a colorectal cancer, well, that essentially should portend no increased risk, and screening recommendations are the same as for average risk individuals, starting at 45 and then going every 10 years in the case of a colonoscopy. So we recommend obtaining a clear documentation of the histology of the adenoma or polyp in the first degree, because we get a lot of patients reporting that, say, their sibling or their parent had a polyp. And that alone is not sufficient. If we can't get that histology, we recommend assuming it wasn't advanced, only because it's so common to have non-advanced adenomas. And remember, benefits of earlier screening are highest when the individual, your patient, is younger than 50. After age 60, even with a family history, it's unlikely to confer an increased colon cancer risk. The other thing we addressed in our guideline was quality indicators for colonoscopy. So the idea is that a high-quality exam is associated with a lower risk of post-colonoscopy colorectal cancer, and that's truly what makes colonoscopy effective. Adenoma detection rate, or ADR, is a validated quality indicator and one that we need to measure and track. How it's defined is it's a provider-level variable, and it's the number of screening colonoscopies where one or more adenoma is found, divided by the total number of screening colonoscopies performed by that provider in a given time period. And the benchmark that's been set is 25%. Again, the aspirational goal is much higher than that, but at below 25% is where we start worrying that there might be quality issues and there's room for improvement. So this begs the two pressing questions. One is, as we lower the screening age, what can we expect in terms of prevalence of neoplasia and adenoma detection for endoscopists in this younger age group? So let's look at some data to inform these two questions. What we do know is, as we said before, the risk of adenomas and cancers increases with age, and that ADR is a validated quality indicator. What we don't know is what is the prevalence of adenoma in an asymptomatic younger individual, because we've never screened them before, and what impact lowering the screening age will have on the endoscopist's ADR. So this has been looked at by different studies. This is one of the first studies. It's the New Hampshire Colonoscopy Registry, and they looked at data over a 5-year period. They didn't have a purely screening group in the 45 to 49. So what they took was individuals coming for a diagnostic colonoscopy, indications being abdominal pain, constipation, or some non-high-risk indications. And they compared the findings on colonoscopy in this younger group to individuals 50 to 54 and 55 to 59. They found very similar rates of advanced adenomas and colon cancers in the younger group, suggesting we may not see any difference. So we've looked at this in multiple endoscopy centers in a community practice with over 223 average risk colonoscopies, with 99 endoscopists over a 5-year period. And we found that the adenoma detection rate in this younger group is several percentage points lower than ADR in 50 to 54-year-olds, and about 5 to 10 percentage points lower than 50 to 75-year-old screening population. Particularly in women, this difference was quite marked, with younger women having much lower adenoma detection rate. So we actually model this as having an effect on the endoscopist's ADR. So depending on the proportion of an endoscopist screening colonoscopy, being that younger group, this is the change in their ADR they can expect. So if 5% of their screening colonoscopy population is this younger group, there may not be any change in the ADR, but as that proportion increases, you see a small drop in the ADR. However, it stays above that minimum threshold of 25%. So we can expect a lowering in the ADR, but it should still stay above the benchmark. And then we looked at the same question in GI Quick Registry, which is a national database of colonoscopies from across the US. We looked at over 2 million exams by 814 endoscopists from community and academic practices across the US. And again, you see that the ADR is several percentage points lower in the 45 to 49-year-olds compared to 50 to 54, and about 8 percentage points lower than 50 to 75-year-olds for screening. So that kind of tells us that we may see a small drop in our ADR, but it stays above the minimum threshold. All right. In the last few minutes, I'm going to turn to what the future might hold for the field of colorectal cancer screening. And this is certainly an area we're very excited about. So there are very many blood-based tests under development. And the idea of these blood-based tests is we used to be able to only detect cancers at a very late stage, by the time there's enough tumor shed to be able to be detectable in the blood. However, newer technology allows us to detect cell-free DNA, looking at proteomics and metabolomic signatures, which allow us to start picking up cell-free DNA and tumor signal much earlier in the colon cancer pathogenesis. On top of that, we now have AI and machine learning tools. So these algorithms are very smart, and they get smarter over time once they get trained to understand patterns between normals and cancers. So that, along with several very powerful new platforms, has really made the field of blood-based cancer extremely important and something that we can expect to see in the next few years. There are many ongoing studies with blood-based tests. And in the next few years, we expect to see the final results of a lot of these very large-scale trials. So this field will change very rapidly. And then the question is, how will blood-based tests fit in our current paradigm of colon cancer screening? So with a lot of interest from Medicare has truly set the bar of what they would consider for national coverage in terms of a blood-based test. And their remarks are that if it meets 4 criteria, they would consider it for approval. 1, the sensitivity for detection of colorectal cancer has to be at least 74%. The specificity for colon cancer detection has to be 90% or higher. The test needs to be FDA approved, and it needs to be guideline endorsed. And if a blood-based test meets these 4 criteria, it would be considered for national coverage. So now there's the bar's been set, and there's a need to meet and exceed these thresholds to get blood-based tests approved and in the market. So, and there's a lot of important research going on in this arena. There is one current blood-based test available. It's called the Septin-9 or methylated Septin-9. And right now, it's an option for patients not willing to undergo stool-based test or colonoscopy for colorectal cancer screening. The reason the test is not recommended first line is because the initial test had a very low sensitivity, much lower than that 74% bar. However, with increased iterations of the test, recent studies seem to suggest that the sensitivity can be as high as 74%, specificity 87%. So you can see it's starting to get very close to that threshold set by CMS. So more to come on that, but again, this is a very exciting field. And on that note, I refer you to this recent review on the topic, where we've summarized just a few of the stool and blood-based tests that have either completed their recruitment or are expected to be completed very shortly by the end of this year. And you can see there's many tests in this space, and it gives you a little bit of information of the technology of the tests and the expected completion. One of these tests by Grail is actually currently available as a lab-developed test in the US. It's currently not covered by insurance. It's an out-of-pocket expense, but nevertheless, it is available, and more data will be forthcoming on these tests. So it's an exciting field to watch, and there's much more to come. So in summary, there's a rising trend of advanced neoplasia and colorectal cancer in 45 to 49-year-olds. The prevalence rate of neoplasia in this 45 to 49-year-old group seems either very similar to 50 to 54, with maybe an absolute reduction of 0 to 5%, and then maybe lower when you look at older individuals, 55 and older, or 50 to 75. The ADRs in 45 to 49-year-olds are lower than for 50 to 55, and certainly lower than 50 to 75. And the absolute reduction is somewhere between 3 to 7%. And with these 45 to 49-year-olds now added to our screening pool, we now need to think about expanded colon cancer screening approaches. And truly, with availability of so many screening options, the emphasis is truly going to be on adherence, meaning which is the test that patients are most willing to undergo. Because as we've all heard, the best test is the one that the patient is willing to complete. So if we can find out what test may work for which patient population, offer them that test and have it completed, that's truly the goal of colon cancer screening. And there's some promising blood-based markers for colorectal cancer that are under development, and we expect to see more on these tests in the next 1 or 2 years. So I would say the story is not over yet. In fact, it almost seems like we're at chapter 1 of this exciting new area or era of multiple test options, including, for the first time, blood-based tests, which have the potential to be very disruptive and change the paradigm of screening. Colonoscopy will still be an important modality. And if not for screening, then it might be that step 2, that after this blood or stool test, it's the test that needs to be done for that individual. So that will keep demand of colonoscopy pretty high, but we'll be able to use perhaps our resources a bit better, and at the end of the day, get patients to adhere, which is truly our goal.